All right. Well, we're going to go back to neurology here. A different type of brain issue. All right. Well, why don't we go ahead and get started? I forgot this was a 4-course meal at Lydia's, so I think it's probably a good time to have Todd start speaking between the gnocchi and the main course. So it's a pleasure to have Dr. Levine here. Todd is now in Phoenix at the Phoenix Neurological Associates, where he's been for what, 17 years. So people have asked me, well, how do you know Dr. Levine? Did you train him? No, I didn't train Todd. He actually went to med school at Duke and did all of his neurology and neuromuscular training in WashU with Alan Pestronk. And then he went out to Phoenix into private practice. But he had his goal in private practice to do mainly neuromuscular disease. This is not all that easy to do in a practice setting, but he's been unbelievably successful and has really been a model for how you can actually do subspecialty work in private practice. There's not too many examples of that in the United States now. And so as Todd was doing his neuromuscular practice, we started talking a little bit about projects, but I didn't know him very well. And then I got to know him real well when Dave Saperstein, who was on our faculty, decided to go work for him. And then we became very close, and Todd and I have been very tight. Sort of, you'd think it would have the opposite effect, but actually we got very close after that, and as I still am with Dave. And so we began collaborating on really a lot of projects over the last 10 years. We began collaborating so much that we started a website together, which you all need to check out, ricksrealneuromuscularfriends.com, rrnmf.com. Some of you are on it, but Todd's the co-founder of that with me and John Katz. And now we do this course around the country where we do update neuromuscular disease on a Saturday in some city and give CME, and Todd and Mazen Damachki and John and I do that course. So Todd and I have been spending a lot of time together. So we have a lot in common. You know, we're both neurologists. We're both interested in neuromuscular disease. We were both raised Jewish. We're both not very Jewish. We both we like to teach, and we like to do research. So there's all these things we have in common. But you know, Todd's he's like the nicest guy in the world. So we don't have everything in common, you know. But it's close. It's close. So anyway, when I like to get all of my close colleagues around the country to bring them into Kansas City to have them give neurology grand rounds. And when I put this together, after he agreed to give grand rounds, which he'll do tomorrow, I realized we needed another spring event for the Kansas City Neurology Neurosurgery Society. So I asked Todd if he would do that too, and he agreed. And I figured a great topic for a dinner talk is what's Todd's view of the world now in 2015 with regard to neurology practice. For someone who's been very successful in a true private practice setting, again, where most people have not been able to pull that off, and the challenges with that. So we're very excited to have Todd here. He also has some academic titles. You know, he's in private practice, so it's like, I don't need no stinking academic titles, but he's got one in Phoenix at the University of Arizona, but as one of the founding members of the RRNMF, this is real, he's also an adjunct professor in our department because we do so many things together with research and teaching. So we were able to totally justify him having an adjunct professorship in the Department of Neurology here at KU. So he's really a Jayhawk too, even though he went to Duke. Yeah, right. So anyway, long introduction, but Dr. Levine, it's just great to have you here. So thank you.
But the idea behind this is obviously that to succeed and make a living in private practice these days, which really means doing what we like to do, right? So we like doing neurology, but if that's our job, we would also like to get paid to do that job. It does take a little bit of work. And so what I'd like to do is kind of just sort of historically go through kind of where we are and how we got to where we are in medicine in general, which is not necessarily specific for neurology. And then talk a little bit about what I think the future might be. And it'll start off a little pessimistic, because obviously most of us are probably a little pessimistic about where we are. But hopefully there's a little bit of an optimistic feel to this at the end. So the first question is, how did we go from this, which was this successful, respected, wonderful figure of a doctor, which is what our parents grew up with, thinking about as doctors, to this, which would be a very disgruntled, angry drug addict doctor, which hopefully we're not in the room. But there's been a clear change in how we as doctors think about ourselves and also how the world thinks about us, certainly how the people in this country think about us as doctors. And having to listen to my mother talk about her doctors, I can clearly see that. So I thought I'd start with a little bit about just kind of the history. And I wrote reimbursement in neurology, but really this is about medicine in general. So Medicare Part B was created in 1965, and the idea was to help patients pay for health care that they couldn't otherwise pay for. And the idea behind this was that the government would pay doctors for doing a service. So if you performed an EKG, you would get paid for doing that service. And that seemed to make a whole lot of sense. And so if you look at physician reimbursements between 1965 and 1987, it basically grew astronomically. So it grew 18% per year over those 22 years. And one of the reasons for that was, were we doing too many things? So if we were paid for doing things, then the incentive was to do more of those things. So surgeries, EKGs, EMGs, whatever it might be. But there was a clear perception by the government and also by people that providers were driving the cost of healthcare. And in addition to that, the fact that physicians could be paid for doing things on that fee-for-service model by the government led physicians to say, hey, we can start to capture this. So we can create physician-owned hospitals and physician-owned diagnostic centers, and we can control all of this. And so physician incomes rose dramatically during that period of time. And as you might expect, there was a backlash that was going to be coming down the road. So in the 80s, the government said, okay, we have a problem, right? So a patient can have a stroke, they can go in the hospital, they can sit there for 3 weeks, and the hospital can bill for every single day that the patient's in the hospital. So we can't do that. We need to incentivize hospitals and doctors to take better care of the patients and to get them out faster. And so they came up with this concept of the DRG. So the DRG system was created in 1983, diagnostic related groups. And so what the government tried to do was to say, okay, if you have a stroke, that's worth $5,000. You're going to get those $5,000 whether the patient stays in the hospital for 2 days or whether the patient stays in the hospital for 10 days. So during my residency, there were literally people that followed us around as residents saying, you got to get the person out of the hospital. You got to get them out of the hospital. Because the hospitals knew the longer they stayed in, the less money they made. But that was the whole concept behind this DRG system. And in fact, it worked. So when the DRG system was instituted, a number of different studies, it drove down the cost of health care for taking care of those people in the hospital. And then most importantly, it drove down the length of stay. So we didn't keep people in the hospital as long if there was a real incentive to try to get them out sooner. The problem with that was that it also created certain shifts in healthcare. So as opposed to the hospital being the center of healthcare, where everything could be driven by the hospital, there was now an emphasis on getting patients out of the hospital. And for neurology, that's been a very important step. So neurology, again, when I was a resident, was an inpatient service. MS patients were taken care of in the hospital. Parkinson's patients were dose adjusted in the hospital. It's rare now for me to admit an MS patient into the hospital or have a PD patient in the hospital. It's all done as outpatients. And so there's been this tremendous shift away from hospital care to outpatient care. And then this also led to a very important emphasis on rehab hospitals and SNFs and trying to get that care taken care of as well. So as an example, if you look at Alzheimer's patients, there's an average they live 10 years after their diagnosis. In 2012, the estimated cost to the US of taking care of Alzheimer's patients is $200 billion. That's the cost of the GDP of probably most countries in the world. But interestingly, neurologists have gotten almost none of that. right? So all of that care is delivered by people other than neurologists. So again, this is our field, just as one example. And neurologists really haven't figured out how do we capitalize, how do we deliver care to these patients and capitalize on that $200 billion. And what that's going to amount to, and this is sort of a theme for this whole talk, is we have to figure out ways to deliver multidisciplinary care. Because what neurology has become is outpatient-focused care of patients with chronic diseases. So whether that's Parkinson's or Alzheimer's or ALS or MS, whatever it is, we can deliver better care to these people through this multidisciplinary model, but neurologists really sort of haven't started to think about how we're really going to kind of capture that. So because of this shift in healthcare, in the 90s, we saw the emergence of managed care organizations. And these have gone by a lot of different names, and they still go by different names now. But the idea here was, could we provide care in a more capitated model? Right? So if you're, instead of saying taking care of a disease, if you take care of a patient per year, then maybe there's an incentive to keep that patient healthy, because you're not getting paid for really taking care of their disease. You're getting paid for the person in general. It was a very good idea, but in general, the belief was that it led to limitations in care. So the MCOs, the managed care organizations, had no real incentive to provide care because, again, it cost them money. So they tried to limit the amount of care that happened. And then also in '89, hospital revenues began to fall, and then the federal government began to introduce a new system of reimbursements called RVUs. So RVUs were introduced to try to improve on some discrepancies that people felt were in the system of reimbursements. So procedure-type oriented physicians were paid a very high amount, and non-procedure type physicians were paid a very low amount. And so they introduced this RVU system, which was meant to try to level that playing field a little bit. And in fact, it did that. So in the 1990s, if you look at family physician income, it went up by 35%, where if you look at ophthalmologists, it went down by 18%. So again, what they were trying to do was try to reimburse physicians for the intellectual type of care that they provided, and not necessarily just the procedural care that they were provided. Unfortunately, in the midst of that, recently we had EMG reimbursement kind of get caught into that same thing, which is the government looks at procedures which are costing them a lot, and then they say, okay, we'll pay less. So in the same year, again, neurology wasn't the only field to have this happen, but in the same year that EMGs were cut by 70%, if you look at pathologists, their reimbursement for doing an H&E slide was cut by 70%, because they felt, well, pathology is all now automated. It's not the old days anymore where you have to pay somebody to hand stain it. Now you take a piece of paraffin-embedded tissue, you stick it in a machine, and it spits out as many slides as you want. So overnight, just like EMGs got cut, pathology got cut by 70%. So again, they're trying to get away from this whole procedure reimbursement. If you look at neurologists in particular, because of these cuts, in a survey done last year, 86% of neurologists said they were negatively impacted by the EMG cuts. And on average, the average neurologist lost a third of their income. So literally overnight, neurology reimbursement went down by a third. So the bottom line is it's not really much of a wonder that it feels like over the last 20 years, everything has been geared against us. The government is trying to ensure that we make less and less money. So in part, that's true. But it's also, I think, in part, and you hear this all the time, which is that physicians don't have a strong enough lobby. And it's true, we really don't. If you compare it to pharmaceutical lobby or the hospital lobby, our lobby is much weaker. For reasons that I don't quite understand. And so this section is designed to tell you that we're actually kind of important, right? So the healthcare system wouldn't really work without us, and it needs us. So if you look at just what was paid to providers in 2010, it was $500 billion. Okay, again, an astronomical amount of money, and that was 750,000 different healthcare providers that are receiving some amount of that money. So when you say, well, we're not powerful, we're unbelievably powerful. I mean, that's an astronomical amount of money. But despite that, we sort of have not organized around that in any meaningful way. Also interesting, as I was doing some of this research, the last 5 years, or I guess now 8 years, there really has been a drop in just the number of visits to physicians. And a lot of that had to do with the economy. So when you look at the number of patients going to see physicians between like 2007 and 2012, it's down by about 10%. And they attribute a lot of that to patients just not having the money to be able to seek out the health care. If you think about the Affordable Care Act, the healthcare reform law, in 2011, a survey, 2/3 of physicians thought it was bad. Okay, so we did not like Obamacare. I'm not necessarily pro or con that, but the bottom line is we didn't really like it. And then, at least until today, I'm not sure if anybody saw that, but the House today did finally repeal the SGR, and the president has said he will sign it. So presumably the Senate will pass it, but the SGR finally, I think, will get resolved. Everybody familiar with that? Sustainable growth? Yeah, so the problem was, this is what, 7 years ago. The government needed to cut money from their budget, and they didn't know where to cut it. So what they said is, we're going to cut Medicare reimbursements by 3% a year for the next 7 years. So over 7 years, there'll be a 21% across the board, just total. And every year, the physician lobby and everyone says you can't do that. Physicians won't be able to take Medicare patients anymore. And every year, Congress says, okay, we'll delay it by a year. And they simply needed to repeal it. It was a terrible idea. Interestingly, the $400 million that was supposed to be saved by the SGR just seems to go away. So they actually don't have an answer to how they're going to save that $400 million. They're just ignoring it for now. But they are actually, it looks like they'll finally get rid of that. So what's happening to private practice? Here's the ground rules. They're not good. So the ground rules are, your income is going to be controlled, but your expenses will adjust with the market. So in private practice, what we pay for our lease, what we pay for the rent, what we pay for electricity, and our staff, and our health insurance all goes up every year, like everybody else's goes up. Our income either stays the same or goes down every year. Okay, so if you were going into a business where I said to you, your income will never change, but your expenses will continue to go up, if you're 30 years old, would you go into that business? Probably not. Okay, it's just not a sustainable model, and that's the model that's come up. Interestingly, this is another, again, just great facts I found. We spend 8 times as much on our office staff billing for patients as Canadians do for the same procedure. And if you look at the average doctor, it costs $85,000 a year just to do the billing for that doctor, per doctor in this country. Okay? So there's a real problem, again, with this system. And those numbers are just going up and up. There's nothing that's happening to control those numbers. So half of the physicians in this country say they make less than they did 3 years ago. I think if there's any private people in this room, including myself, that's probably true. Only 18% said that their income had increased. So again, we are making less and less every year. How much is spent in healthcare in this country? Again, it's an unbelievable number. It's $2.5 trillion. So $500 billion of that goes to physicians. $2 trillion is basically hospitals and pharmaceuticals. So you have basically an unlimited demand, but very, very finite resources. Again, a system that really isn't sustainable, which everybody recognizes that it's not sustainable, but nobody's really come up with the problem. So this was a survey from 2012 where they asked private practice doctors what their view of the private practice model was. A quarter of them said it was a dinosaur that was about to go extinct. Half of them said it was on very shaky ground, and only 14% thought private practice in this country was a viable model for healthcare. So again, it's a pretty dismal outlook for private practice in this country. While all that's going on, this is for the residents and the students in the room, this is another enormous problem, which again, the government has not figured out what to do about. So we have 36 million baby boomers that are just about to enter Medicare. And what that's going to do is that's going to lead to a shortfall of about 130,000 physicians in this country. Okay? So we are simply not going to have enough physicians, let alone whether physicians stop practicing. But if you just continue the physician accrual as we currently do, with the patient accrual as we do, we're not going to have enough doctors in this country. So medical schools have tried to fix this problem. So they have increased the number of medical students. In 2002, there were 16,000 medical students. In 2015, this year, there were 20,000. So it's a 22% increase. Osteopathic schools have increased. They've actually doubled in the last 10 years as well. But because of that same Balanced Budget Act, the government is no longer funding residency spots, and they're not increasing funding to residency spots. So what that means is you can produce as many MDs as you want, but you don't have any residency spots for them to go into. Okay? So we're obviously not going to have specialists produced at nearly the number that we need to. So that should drive the market price up if you believe in any type of economic model. If the resources are less, the reimbursement or the cost for that should go up. Which you then might also think, well, this is going to lead to an increase in reliance on mid-level providers, which is a great model. We've got 2 mid-levels in our practice. We have 5 neurologists and 2 mid-levels in our practice. Problem is, NPs are also scarce. So if you think about NPs and PAs, the average age is 50. So most of them tend to go out, they practice for 10 or 15 years, then they go back to school to get their advanced degree. So you're not seeing a lot of 25, 30-year-old NPs in this country. So their lifespan or their work span is relatively short. So all that sounds very depressing about private practice, and that leads to this question, which is, should we all just get employed? Okay, do we really want to be in private practice? Is there any reason to be in private practice? Or maybe we should all just go work for hospitals. And sorry, this is actually turned. But this was actually a survey of hospital administrators. And they asked the hospital administrators, why do physicians come work for hospitals? So the number one reason was they want more income certainty. Okay, so 78% of them said they want a fixed salary. They don't want to have to worry about anything. The second is they don't want to have to deal with the hassles of insurance. They want someone to take care of that billing that's going to cost $86,000 per year. So it's true, hospitals will take care of all of that. Third is doctors are fearful of healthcare reform. So doctors don't know what the future holds. They don't want to start a business and then lose the business. And so they just go work for doctors. And then there's a bunch of little things in there that basically has to do with the hospital trying to buy up doctors and why that might be beneficial for the hospitals. But the main reason that hospital administrators think they're acquiring physicians is because the physicians want to be acquired. Not because the hospitals say I need to have 400 neurologists, but because they think neurologists can't make it in private practice, and therefore they want to come work for the hospital. So between 2003 and 2010, the number of hospitalists in this country have tripled. The AAN believes that the number of neurohospitalists have increased by 5-fold. Okay? So more and more people are finishing the neurology residency and saying, you know what, I'll just go do neurology work in a hospital, do my shift work, and be done with that. If you look at hospitals with more than 100 beds, basically all of them now have hospitalists. So the days of primary care physicians managing their patients in a hospital is over. I think we all probably know that. In 2006, the number of physicians who submitted no hospital bills, so basically this means physicians who no longer go to the hospital, is basically a third, 30 or 40%. So that number is growing. So physicians are just not going to hospitals anymore. So there's going to be one group of hospitalists and another group that never go to hospitals anymore. And more, at least in Phoenix, that's become the case for neurology. They're the ones that work in hospitals and the ones that don't. But this bottom line, I'll show you a couple pieces of data about this. To me, this was really interesting. Now, it's hard to do this accounting, but if you look strictly at accounts receivable for physicians, hospitals lose money on physicians. Hospitals don't make money on physicians, which is why, if you go back to the reasons why hospitals acquire doctors, profit wasn't even on there, okay? And I'll show you why profit isn't on there. So this is from 2011, and you can just kind of look down here. What they did is they said this is the non-hospital group, and they said the best, meaning a really successful non-hospital group, so a successful private practice. And then this is the typical private practice. This is your best hospital group, and then this is kind of a typical hospital group. So for anyone who's in practice or thinking about practice, the first thing to look at is this line, okay? Overhead, right? So when I left my fellowship and went to private practice, the people I joined said overhead's really important. After 17 years, I've kind of learned overhead is really important, okay? So if you're spending 83% of your money on just your overhead, you can't make money, okay? But then if you look down here at the bottom line, so if you just look at sort of the typical group, so your typical non-hospital physician would make $280,000, and your typical hospital physician would make $70,000. Now that doesn't include the salary of the physician. So if you're the hospital, the doctor brought in $70,000 and you paid them $130,000. So you've lost $70,000, $80,000 on that doctor. Okay. Even if you're a great group and you're bringing in $260,000 on a doctor, you're still barely making money on that physician. Right? So there really is a lot of data to suggest that on average, the net collected revenues for a hospital physician are $100,000 less per FTE than a private practice physician. So you don't go into a hospital system to see more patients and generate more money for the hospital. You're going there for income security. There's a little less drive to do that extra procedure, to do that extra patient. And so the median practice loss per FTE was $190,000. But again, for the hospital, this is the sort of the take-home message is it doesn't take into account the downstream revenue, right? So if you're a neurologist in a hospital, you're ordering 300 MRI scans a year, and the hospital makes money off of that. You're ordering angiograms and EMGs and all other kinds of procedures, which isn't really figured into this. But just in terms of the RVUs that physician generates, it's significantly less in the hospital than it is in private practice. So despite all of that, and for all the appearance of change that you'd expect to see, there's still a model for private practice physicians. So in 2008, almost half of the physicians in this country were still in practices of less than 5. And a third were still in solo practice. In metropolitan areas of 1 million or more, again, 40% of physicians are in groups of less than 5. So not everybody's running to join hospitals or to join kind of the mega groups. Size matters a bit, but it takes a while before size matters. And so basically, physician productivity declined as the groups went from 1 to 8. And in fact, you didn't see a real increase in revenue until the groups are greater than 25. So if you form the mega group, the 40, 50, or in Phoenix there's 140 anesthesiologists, there's definitely strength in numbers in that way. But otherwise, until you get to a big enough size, it doesn't really look like that because you have so much more administrative complexity to really have to overcome. Again, the other thing about this argument is it also doesn't take into account the monopoly idea, which is if you're big enough, you can argue for better reimbursement from the insurance companies if you control a large enough part of the market share. But in general, getting bigger isn't really necessarily the answer. What is the answer, again, is overhead. And this is really not very fun. I have said that somewhere in residency it'd be great to teach like a couple-week course on economics and business management, because if you start your own practice, you are starting a small business and you don't know anything about starting a small business. But the idea here is the best performing groups will have the lowest overhead. So that is really, really important. And interestingly, there was this very strong correlation between having lower overhead and actually working more. So if you can resolve a lot of those issues and streamline the practice, it actually allows you to work more efficiently and produce more revenue as well. So in practice, overhead. So how do we fix this broken model? And this is okay. So hopefully a little bit more positive now. So my argument is we're all pretty smart in this room. Okay, I mean, like we didn't go to med school and residency, and particularly neurosurgery, if we were dumb. Okay, but somewhere along the line, we kind of stopped trying to come up with new ideas. And so what I'm going to try to argue is we need to come up with some new ideas. It's an interesting quote, actually, from a journal called Health Affairs, where if you think about it, the office and exam room that we go into today when I go see my doctor is no different than my grandfather went, 80 years ago. What else is like that? I mean, was it that perfect 80 years ago? They were like, no, we don't need to change it. I mean, there are probably much better ways to do things than the way that we're doing them, and yet we just get fixed. It's like, no, you have to come and check in and move here and move here. There are probably very simple things to think about. How does the exam room set up? How does the patient flow? How is billing done? All these things that, again, haven't changed at all, that really are tremendous areas for innovation. Again, I'm not sure I have the answers, but keep that in mind. I think as you go through life, just say, well, why do I have to do this the same way? So what are the best management practices? Again, this was from a study from a medical economics journal. They think that cross-training staff is very important, so staff can move to different positions. Using mid-levels. This one is actually I've hugely started to focus on in my office. So we all know that if you go in for a doctor, you have to pay a copay. For some reason, the practice that I inherited, which was 50 years old, if people had procedures, you didn't collect the copay because you didn't know how much the procedure was. So the example would be an EMG, which is $300, and the patient owes $60. Well, we'd have to then try to collect that $60 after they left the office. That's very hard to do. That's the reason you collect copays up front, is it's hard to get it after the patient's already had the service. So the same day of care payment of copays is really big. Subletting space that you're not using, obviously finding an EHR that seems to work really well. But these are a few innovative practice models which I thought were interesting. So one, for people that are just finishing residency or fellowship, is the idea of a micro-practice. And so I'd never heard of this before. The idea here is you rent one exam room from somebody else. It costs you almost nothing, right? And you have a little cheap EHR on your laptop. And you go out and get your patient from the exam room, you bring them back to your office, and you see them, and then they leave, and you get the next one. It's incredibly cheap. They think you can start up a practice for $15,000 that way. The patients like it because they have access to you. There's not a lot of front office staff. They can call, they can get you. So kind of the idea of a concierge practice, but at a very, very low level. And it's a great way to get started. So lots of doctors are starting this idea of micro practices. Thinking a little bigger than that is the idea of a medical home. And this goes by a lot of different names these days. But again, this gets the idea of multidisciplinary care. So the idea is, how do we take comprehensive care of a patient? Number one, it's what patients want. Number two, it's probably better for the patients. And there's a way to capture that revenue. So there have been a number of pilot projects where you can see you take like 5 physicians, some MAs, LPNs, and PAs. You give improved access to the physicians. And they've been able to show that they can reduce ER visits by 30%, they can reduce hospitalizations, and they can save about $18 per patient per month, which doesn't sound like a lot, but these are the types of projects that you can then go to the insurance company and say, okay, I'll split the difference with you. Right? So you have 3,000 patients in your practice, you make $9 a month, that's $27,000 a month, that's $400,000 a year, and you're providing better care. So these types of medical homes are popping up all over the place, and the government's very interested in you doing them. The insurance companies are very interested. Takes a little more work up front, but it actually does provide much better medical care. Everybody thought concierge medicine might be a great approach. It's sort of there, but it's kind of fizzled. The idea is basically that you can have continuous contact with your care team. You pay a monthly or an annual fee, so the physician makes extra money. They have to see fewer patients because they're making extra money. But the bottom line is this really hasn't grown very quickly because it's expensive. And the vast majority of the patients aren't going to be able to do that. And the single biggest source of bad debt in healthcare is not uninsured patients. It's actually patients that don't pay their copays. So again, asking them to pay another monthly fee on top of that, it's just not going to, this isn't going to be the answer. Some people can get away with it, but it's not easy. This concept emerged in New Jersey. I think this is Jersey, or Los Angeles and New Jersey. The idea, I like the word called the extensivist. And the idea here was to pick chronic illnesses that you're going to treat better. So whether it's diabetes or heart disease, you integrate multiple care providers, and the goal is to keep patients out of ERs and out of hospitals. This GI guy in Los Angeles had 26 sites that he set up to do this with. These are frequent flyers with cirrhosis and varices and all kinds of bad liver diseases. And he was able to take care of them with 18% lower cost than Medicare averages, reduce hospitalizations by a quarter, reduce length of stay by about 40%. And again, because he did this as a contract with Medicare, he was able to benefit in the financial savings. And again, the government really is looking for these types of models. This was another doctor in New Jersey who developed a SWAT team, what he called the super users in Camden, New Jersey. So he found that 1% of the Camden population accounted for 30% of the community's healthcare resources. And so he enrolled this 1% into this program. They were costing $1.2 million per month in ER visits, and he cut ER charges by 40% and hospital charges by 50%. So the point is that you can actually deliver better care cheaper. We all kind of believe that. It takes a little bit of work, but it's definitely doable. So the bottom line is that providers, hospitals, or physicians, somebody is going to have to take more responsibility. My argument is it should be us. We should figure out what we like taking care of. We should figure out how to take care of that better, and then figure out how to make money off of doing that, okay? That's sort of the holy grail. We're going to have to organize a little bit to do that, and then provide comprehensive care. So again, same survey, how do you believe reform will affect the quality of care you're able to provide? 60% thought healthcare reform would make the quality of care worse. And my argument is it shouldn't make the quality of care worse. We just have to think a little bit smarter and figure out how to do it better. So just a couple last points. So again, there's a couple of changes that are coming. One is the SGR. The other is Medicare's eliminating the site of service, or trying to eliminate the site of service. So this has basically said that physicians are paid more in hospitals than they are paid in the office. They're actually trying to get rid of that now, and that's up in debate in the Congress. But it will actually reduce somewhat the hospital's incentives to buy physician practices. Because in the past, if a physician made $300,000 in revenue and a hospital can make 80% more than that just by buying them, it was a benefit for them to do that. And that may go away. So what can we do to improve care and revenue today, like literally today? So I've got two concrete examples and then just a smattering of other examples. So the smattering of other examples is, these are all things that are available to us that we typically don't do in private practice. So drug dispensing, we generally don't do it. Rick and I do it. We dispense IVIG in our office. That's drug dispensing. You can dispense anything you want. You could dispense oxycodone. You could dispense gabapentin. There is money to be made in that. You don't have to be a pharmacy. And that's something, again, I don't do that other than the IVIG, but it's an interesting model, one that we've started to look at. Ancillary services like PT, OT, speech, those types of things. In-home care for dementia, if you've got an interest in dementia, there's a ton of an opportunity for that as well. And then imaging still isn't dead. I don't have imaging, but it still is something that you can do. But two specific examples you could do today. How many people bill for care plan oversight? All right, okay, so this is a legitimate code, G0181. How many of you sign the sheets that come from home health or PT? All right, okay. You sign 4 a day, 5 a day? Okay. All of that is billable, and we don't bill for it. Okay, this is the code. All it says is you have to spend 30 minutes a month without seeing the patient, and you have to see the patient in a 6-month window of that bill. Okay? And you can generate a bill for that. They have the same one if the patient's in a hospice, but usually the hospice is billing for that, so we don't really do that. So what are the requirements? You can't, if you're getting this stuff from a home health agency, you can't have any financial relationship with that home health agency. You can't be an employee of that home health agency. Only one physician can bill for CPO per month. So if their primary care doc is doing it, which they're not because nobody's doing this, you can't, but you can do it. You have to be the one that signs the orders for that service in the first place, but that's what you're signing, which is what you're going to bill for. You have to have seen the patient within the last 6 months, and you provide 30 minutes in that calendar month. So basically all that means is when you sign those silly sheets, if you write on there, I spent 15 minutes reviewing it, and you do that twice in a month, you can generate this bill. And that's all the documentation you need. It's $50, okay? That's close to a follow-up charge. If you have $50 per month, 50 patients per month, that's $30,000 that none of us collect because we just don't think to do it, okay? So again, very easy. You can start doing that tomorrow. Now, it is starting to grow, okay? So between 2000 and 2011, it went from 15 million to 41 million, but you can see that is a fraction of what the 500 billion that we spend is. So the OIG is saying we may start taking a look at it, but don't let it scare you. I mean, nobody's doing it, okay? And it was created for a reason, because they want you to integrate your care. They want you not just to sign it. Take the extra few minutes, look at it, care about it, and generate a bill. It's better care for the patient, and you're making money for doing that. This is the newest one. Anybody billing for CCM yet? All right, great. Okay, so CCM, chronic care management. This started January of this year, okay? I just started doing this for ALS clinics, so you got to start doing it for ALS clinic. Okay, so this is a new code separate from that one. You can bill for both, but this is non-face-to-face patient management or coordination, okay? What makes this one so beautiful is it doesn't have to be done by a physician, So if your MA or your front office person spends more than 30 minutes in a month talking to getting somebody prior authed or getting their imaging studied or doing anything that they do, okay, you can generate this bill, okay? It's $43 a month. There are some catches to it. There's only one that's significant. They have to have more than 2 chronic conditions. The idea is chronic care management, but there's no definition of what that is. So that could be ALS and spasticity. It could be MS and headache. It could be, cervical myelopathy and arm numbness. I mean, there basically is no definition. So if you see 1,000 new patients a year, if 20% of those are Medicare, that's $103,000 a year if you start billing for CCM. And again, it takes no physician time. It's $100,000. We don't, again, do anything to do. So what's the scope of service? So you have to have, that should be EHR, sorry. You have to have an EHR, but I assume we all have an EHR at this point. There has to be 24/7 access for that patient, but that just means they have a number they can call. It just means that somebody's on call. So assume any of us that are practicing have somebody who's on call. There has to be continuity of care with one provider, so when they come back, they're seeing you. You assess their health needs, you have an electronic care plan. There are companies now, because again, this just started in January, so we're only 3 months into this. There are companies now that will sell you the technology to document all of this directly into your EHR if you want to, but there's no requirement for that. So if it's $43 a month, I talked to one company, they want $10 a month, and they'll just make it all seamless. But again, I don't know if you need to do that. And then the catch is this bottom one, which is the patient signs an informed consent. So unlike the first one, where there was no informed consent, this one the patient has to say, I know you're going to do my chronic care management. And that, again, only one physician can do that. So I thought there'd be this race to get everybody on, but again, nobody's doing this. It can be anybody in the office. Doesn't have to be a nurse, doesn't have to be a doctor. Front office staff is just as good, and all they have to do is document that 30 minutes was spent, and they generate the bill each month. Again, it's Rick and Mazen and we all have multidisciplinary ALS clinics. I mean, the amount of staff time that our staff spends outside of clinic time taking care of each patient is astronomical. And again, not to be billing for that is just money that's very easy to collect. So the bottom line is I think there's a lot of different practice models. I mean, employed models are great, private practice models are great. It's figuring out what you want to do, what's best for the consumers. I think diversifying is important. So the more things you can offer, the better. And to me, what we have to start seeing is doctors that are willing to experiment with different ways of delivering care. And again, there are some of these little things like the CPO and the CCM provide ways to maybe have a little bit of extra time to spend to work on that, even if there aren't the big plans of solving all of Camden's problems. But I still think, again, I'm not giving up private practice yet. So I still think there's ways to really be good doctors and deliver great care, but still make enough money that you go home and you're kind of happy with what you did. So I'll stop there.
So the first thing we need to find out tomorrow, Abe, is are there RVUs attached to those? Because
Medicare. Right now, insurers aren't paying for it, so yeah, it's just Medicare. Yeah. The insurers probably will. For the first one, for CPO, some payers will pay for it. But for CCM right now, because it just started in January, the only people are Medicare.
Because for those of us who are in an employment system, or who are going to be in an employment system in the near future, our reimbursement comes from RVUs actually. But it shouldn't make any difference if it's RVUs or dollars.
Yeah.
So that's important. Well, that was great. What about, you sort of mentioned ancillaries briefly, and you mentioned the infusions, but are there, it seems like in your practice, there's been examples of some ancillaries that you started with, but then the margin just became not doable, and so you dropped over time. So.
Yeah, so we had a muscle and nerve pathology lab, right. As well as a skin biopsy lab that we started. the revenue from the muscle and nerve side kind of progressively went down. The revenue from the skin side was still doing good, so we actually spun the skin side off and started our own little company that does just skin biopsies. And then we stopped doing, we still have a CLIA certified lab, so we read them, but we send them to Houston to get processed now. It was just it's a volume issue with the muscle and nerve to really get going. We did start an autonomic lab, which is still doing pretty well. The tilt table got slashed in terms of reimbursement this year, but we still do that. You know, for neurologists, obviously, figuring out how to still do EMG nerve conduction studies has probably been the biggest challenge. We've started to do a lot more what we call EMG consults, where the patient will come in for their new visit, you sort of screen their records, you know they're going to need an EMG, you do it kind of all at once,
Right.
And that makes it a little more viable.
Right.
But you know, for the most part now, the time I'd spend doing an EMG versus the time I'd spend seeing a patient, it's the same reimbursement now.
So in the Phoenix area, what, if you can just estimate, what percentage of neurologists are still in practice and what percent are hospital employed?
It's the West, so it's we're still, I'd say we're about 2/3 or so in private practice.
Really?
Yeah. People are not. The hospitals are. I mean, they're moving in,
Right.
but we just had, you know, 2 large groups, meaning like 5 to 9 in each, leave a hospital system and try to make it on their own.
It's interesting to me how different cities are affected by this at different rates. So as everyone in this room knows, and we're taping this, we'll probably put on the RNMF soon. So in Kansas City, it's basically now 90% hospital employed.
Yeah.
We're the biggest neurology group in town, and we're soon to become hospital employed.
Yeah.
So Dr. Rowe's practice is one of the few private practice groups left in town. So, you know, why that hit Kansas City so hard, I'm not sure. It's, you know, competition, number one,
Yeah.
to hire the neurologist. Yeah, I'm not sure why it hit some cities. But Texas is still predominantly private too,
Yeah.
but it's changing.
Yeah, I mean, Texas kept the reimbursements up higher. You know,
Right.
Phoenix or Arizona, because of the Medicare population, we sort of, our reimbursements went down pretty fast. So I'm not sure it was just that.
And then the other possibility is, and although I don't know why it would be any different in Phoenix, but I just sense that, and maybe some of the younger doctors would want to comment, that for the young doctors coming out of residency and fellowship, it just seems like the way of thinking is more to join a hospital practice and not even consider doing private, where
I agree.
and so I think a lot of it is it's just not part of their thinking when they're going through med school.
Well, I think they probably see more hospitalists.
Yeah.
And it's not a bad job. So they see it, they're making a good living. You know, they don't have all the stresses of managing a practice. I think, you know, obviously there's never been any attempt to try to teach trainees how to start a practice.
It's just so odd, isn't it? So what happens with Abe, and some of the young doctors should speak up, but I know every, March, the graduating fellows start making appointments with Abe to try to figure out, what is this billing stuff anyway? For some reason, they were ignoring it for 5-6 years, and all of a sudden it becomes important.
What's contract? How to write
Right. Yeah, exactly.
Work RVU. Never heard of work
We
RVU.
teach nothing about that in residency.
Yeah, because even if you join a hospital-based group, again, negotiating a contract based on RVU's worked and what the reimbursement is going to be, that's relatively complex.
We've been teaching that. Phil's really taken the lead in our residency now from G1, PGY1.
Really? Yeah.
What's an RVU? What is malpractice insurance? What
Right.
are the practice expense, malpractice, place of service, the different components of it. So
We're not really doing any of that. in our neurology residency training program and fellowship.
Larry, when Larry Writing was here the other week.
Larry was doing a little bit of it.
That's it.
I think
Then
it's-
Abe does some.
Right,
Abe does,
right,
Well, I guess you give him some lectures on that.
right.